Hello everyone, good afternoon. Welcome to this new session of the IWC Clinical Case Symposium. For this session, we are very happy to host two great IWC teams. The first one from Valencia with Sergio Pombo and Vicente Caratala, and the other one for Madrid with Jaime Ruas, IWC Pinal y Asociados. So I would like just to remind you that we would like the participants to be involved in this webinar. So we invite you to answer the polls. We will launch some polls throughout the cases presentation and the discussions. We have Gustavo Gomez and Lucian Marcovici, who are my co-moderators today, our panelists. Thank you for everyone. So I will give the floor right now to Lucian. Lucian, please. Thank you.
So we have a really great cases today, and we will start with Dr. Jaime Ruas. He's part of the Pinal and Asociados group, and he also works as the leader hand surgeon in the Clinical University of Navarra. So Jaime, you are a great expert in wrist surgery, and we are anxious to see your cases.
All right. Thank you, Lucian. So let me share the screen and all that and make it work. All right. So are we there? Yes.
Perfect.
So, all right. Thank you, boss lady, and for the invitation for everyone. So since this is my first time presenting cases, I have a dilemma. So I decided to start with, like I would say in my head, two everyday cases, straightforward, and to open the discussion for some details about that. So first case is ulnar pain in an amateur boxer. So this is a 22 years old girl that is the university student engineer, and she really loves boxing. So for the past 4 months, she has been suffering ulnar pain. So I check on her in the office. She's a hyperlax patient, but the DRUA, she has no signs of instability. And keeping up with the physical examination, she has foveal pain, and there are no signs of impaction or ECU problems or PT or LT issues so far. So very common case in the office, ulnar pain. I do these sports, I'm young, active. She's very clever, by the way. So these are the x-rays that, well, apparently there's nothing that rings any bell. If you want to pick a fight, I'm going to show you the other wrist and the comparison. Is there a ulnar impaction or not? I won't say that. And here you have, because when I present cases, I really like to be super big with images because they're important for you to see. So here you may see or may not see some kind of cyst on top of the TFCC in these coronal MRIs. The insertion seems to be okay. And here, there in the dorsal side, something doesn't seem to be well. So if I am right, I have to stop now. Yeah.
Yeah.
So,
we will.
We stop now, and please, for the attendees, I will share the polls, and Jaime, you can stop sharing your screen,
yeah,
please.
sorry. Stop sharing. Okay.
Lucian.
Yes, I want to ask Sanji Kakar that I see that he's with us. Hello, Sanji. I want
Hi,
to ask you, what do you think is the most important thing to look in ulnar wrist pain in these cases in the MRI? What are you looking for? What are your suggestions for the most important things to seek in an MRI?
Well, good morning, everybody, or good afternoon. It's so good to see you all. And sorry I was a little bit late, but Jaime, lovely case. And Luciana, I appreciate the question. I think, as you said, when you're looking at the MRI, right, obviously you have to look at the clinical exam. There's foveal tenderness. I would argue when you look at those coronal views, she's a young patient. As you follow the thick black central disc to the on the side to the styloid and the fovea, you can see it's more gray. And I actually didn't see a great insertion, robust insertion to the fovea. You see some areas where there's some insertion, but to me, that's probable scar tissue as opposed to the actual TFCC, native TFCC. So I look at the coronal views. I look at the sagittal and the axial views for ulnar triquetral split tears. That's the views that you see it on. And when you look at the axial views, I'll also look at the sigmoid notch and see if there's any dorsal or volar subluxation. And that will also be an indicator of potential foveal TFCC injury.
Maybe, Jaime, I'm sorry, you could show us again the MRI and Sanj can.
Yes, if you look at the coronal sequences, Jaime, that you had. So that's the sagittal. So if you go there, you can see more dorsal aspect, and I think the coronal. So those are the sagittal views. Yeah. So if you look at that, so you can. That's a nice view. So if you look in the bottom left and you start working your way along to the right, you can see the thick central disc, and as you get to the periphery, you can see it's more grey. And in a young patient, right, you would expect that to be essentially more black. Now, if you look at the third image from the second image from the right, you can see how it gets a little bit more black. So I would say to me that this is probably a foveal. I would be suspicious of a foveal injury that is scarred in. So while it might be structurally intact on MRI, it's functionally, it's like toffee, it's stretched out.
Okay, so somebody uses arthro MRI with the insertion of liquid, the contrast liquid, in to see better these lesions. Does someone of you use it regularly, or can you explain people when you use it?
Yeah, we never use. We typically get MRIs without arthrogram. Once I start seeing fluid everywhere, I find it hard to read, to be honest.
Yes.
Okay.
And we don't have it for our daily. We don't have it easily in our daily practice. So for us, it's MRI in our daily practice. You need to get a good MRI and a good radiologist as well, someone you can trust for the images quality.
So I will comment with Dr. Kakar that when you see these images, you may have these doubts. So is this foveal? Is this peripheral? So, I take the report, I read it from the distance and just keep it there, because at least that something is going on around there, and let's see what we find. So maybe the teaching of this is, although you get the best MRI ever and you have some suspicious, in the end, you don't diagnose until you get in my view.
Absolutely correct.
Absolutely. Do we want to continue to see more of the case?
If you don't have other comments from Gustavo or Vincente or Sergio. No, okay.
All right. So let's get back to work here, there. Okay. All right. So here we are in the arthroscopy. So, and this is another thing we can discuss later on because I don't want to stop anymore. So that's the trampoline effect. Sorry, the video is 2 times faster. Oops, let's go back just for a sec. So that's the trampoline effect that could be deceiving. We are checking here what Dr. Kakar was saying, if the foveal insertion is okay. And here, if you want to get to see a peripheral tear, one of the things I want to stress for this case is, unless you go and see if there is a scar, you will never, or you won't be so easy to detect those. So for me, this is a peripheral tear because I can go with the probing. And thanks, Professor Matolan, for the book and everything. So I took all the images from this. So this is the situation that we have to treat. And there's another spoiler here. I recommend you this paper in order for the further discussion about how to pick up these lesions and how to get the diagnosis, because I guess this case, one of the most important things is to get the proper diagnosis and then the treatment, obviously, but the diagnosis is still challenging somehow. So we need to do this. Sorry, I don't have my own pictures on this, but well, you all know this, so I'm gonna skip this. DRUJ portal, we pass one loop, the other loop, we retrieve, we have to take care not to entangle the extensor 5 and 6. So we need somebody to retrieve those. And then we put the nut. I use a Mason 4.0 that is a resorbable suture. And I am very, I won't say the word obsessed, but I take care of to release the traction and to put the recent extension while I'm advancing the knot. So this is how it looks like, pulling the knot without still advancing it to see the effect on the tear. And this is after passing the knot that it seems stable, as stable like it can be when you test your own repairs that you are not always that strong. Another caveat is the post-op protocol. So if we go to papers and the book and this and that, first initial post-op is to stay still and let things heal. And then progressively we start to range of motion. And the last thing we are going to do in my head is axial loading like in boxing. So I keep her 3 months. That was one of the things that was difficult to get in the case, to ask her to stay quiet and be nice. And this is the pictures I had for 8 weeks. So the operated case side is on your right side. This is pronous supination. That's another thing that if you do this open, it's difficult to get a perfect pronous supination. So that's one of the advantages of arthroscopy. There you can see the little scar for the little approach I did to slit the knot. And this is 6 months that you can, if you remember, there was some extension and flexion deficit, and 6 months is okay. And it was already okay at 2 months. And this is the result. So, can you hear that? She punching? Yeah. All right, so I'm happy this end up well, because if she punches me, I'm going to be KO. So I think I have to stop sharing, right? And then we discuss something. So, and sharing. All right.
Thank you, Jaime. Thank you.
Thank you.
Okay, so very, very, very beautiful case.
I will just after share the results of the pose. I will not just Jaime. I will Lucian. Can I speak, please?
Yes, for sure.
Well, Jaime, I have one question. My main concern in this kind of cases is to miss a foveal disinsertion, because if we understand well, you did the hook test.
Yep.
And after you did capsular suture. And my main concern would be to miss a foveal. In this case, you didn't miss anything because the patient is doing well, but you don't use the DRUG view portal. And sometimes maybe we can miss some foveal disinsertion. What do you, because do you think it's enough accurate to do what you did to test the TFC? And
so I see. Yeah, I see your point. So we will use this portal in case of doubt. So if you pull from this and it moves way too much and you are not uncertain about what it's going to be, then we do that. And we also do this sometimes in distal factors too, to check the DRUG, by the way. But normally, if it's attached like it was, I don't want to show you because I don't want to steal time from the others. But unless there is doubt, we don't standardly go and try to see the insertion there.
Okay. And in your X-rays, you did the X-rays in the fist position?
Yeah, I have some more X-rays, but I didn't show for the sake of time.
Okay.
Yeah, I like those X-rays, dynamics. I don't have to do X-ray machine in the office just to check myself, like they did in Kaplan's and stuff. But I will ask those just to see.
Thank you.
So I think the most interesting thing is that arthroscopy gave us the possibility to recognize this type of lesions, because with open surgery, we opened the connections between the capsula and the TFCC. So and this is one of the biggest revolutions of arthroscopy because it gives us the possibility to treat non-foveal lesions, which can be a problem in active patients. Okay, so I want to ask the panel if they do regularly DRUJ arthroscopy, because in my opinion, it's very difficult if the TFCC has a good foveal attachment. It's very difficult to enter, and one of the problems is you can ruin the TFCC attachments when you try to do a DRUJ arthroscopy. So I know that Gerin, Kakar, and Vicente are using also the nanoscope. So I want to hear maybe their experience with the nanoscope evaluation of the DRUJ, because it's smaller than our regular scopes. Gerin, Vicente.
Vincent.
Sorry, Lucian.
Well,
Usually,
no, for me, normally I'm not using DRUJ arthroscopy in every case. Only as Jaime was telling us, only if you have a suspicion of some injury in the DRUJ or in the foveal attachment. It's true that in this case, with the image of the MRI that Sant was talking about, probably I will do it just to check that everything is fine, because you can have not a complete detachment, but a partial detachment of the foveal, and after that you can have a slightly instability of the DRUJ, and it can cause pain or ACU pain, tendinitis or something like this. So I'm not using in every case the DRUJ arthroscopy. Of course, with the nanoscope you can have an easy way to have access to this space, because when the foveal attachment is fine, the space is really close, it's really tight, the area. So with a normal scope, probably is more difficult to have access there. But only in the cases that I have a suspicion. But what is important, as you were telling us, Lucian, is that with arthroscopy we can complete the diagnosis of all the ulnar side of the wrist, because not only is the TFCC, we have the TFCC, we have the ACU, we have the lunotriquetral ligament, we can have chondral injury. So I assume that you, Jaime, you do the exploration of all the ulnar side when you don't only goes to repair the TFCC. We have to check all the ulnar side of the wrist, and after that we have to make the treatment.
Vincente, do you think we can have a kind of ulnocarpal abutment here without a central lesion in this kind, because it's very frequent in boxers?
Yeah, it can be a dynamic case, but in this case, I don't think it's the problem. In this case, the problem probably is that injury of the TFC. But that injury. Another thing is that injury with that scar in the dorsal part of the TFCC is more frequent that you can think. And it's true that sometimes it's not easy to see the injury, because you have a scar, some tissue over the injury. You have to debride that tissue, and sometimes for beginners it can happen that they can see the TFCC with a more or less normal shape, a normal tissue, and they say everything is fine. The hook test is fine, but you have to see that scar, that bad quality tissue in the dorsal part of the TFCC, and clean it. If you clean that tissue, you can recognize the tear.
Yeah, and I think another very interesting issue is the post-op management. Jaime, you showed us that you block the patient for 5 weeks, right? But you didn't mention if you blocked from supination or not, if you use them above the elbow splint or under the elbow splint, or some Munster or something like this.
So some time passed, I was very focus on that, being super conservative, taking the elbow and this and that. But I am halfway now between the French school and my school. So I just put a wrist extension, let the elbow free.
Okay. So nowadays, I want to hear also the other expert, like Ezequiel. What do you think? You also leave the prostransplantation free in peripheral tears in these cases?
I mean, first, regarding the comment about the portals, I never use the DRK portal. Just in some cases, to be honest, rarely. And I rarely do peripheral repair nowadays. 99% of my cases, I perform a foveal reconstruction. And for those cases, I block the consultation for 3 weeks, and then I continue with the short training for 2 more weeks, starting with occupational therapies. But for a case with a peripheral tear, like a repair, like you are saying, yes, I probably block the consultation for 2-3 weeks or so. Yeah.
Okay. Shanj, how do you do it in the United States?
Yeah, so great discussion. So a couple of things. So I routinely do from the radiocarpal joint, right? I'll do the trampoline test, the hook test, and the suction test. And if I'm not seeing pathology, then I'll do the DRUJ scope. And Lucian, you mentioned a great point about you can iatrogenically injure the fovea. So I do the same way that Jeff Ecker has taught us, but I would cheat the portal a little bit more over the ulnar head. So in that way, I'm not going into the fovea, and then I can turn the camera and turn my eyes to look at the fovea. You know, it's a great discussion about the post-operative rehab. I'm pretty conservative. I still keep them in an above elbow splint or cast for 6 weeks, allowing elbow flexion and extension, but no pronosupination, because the stiffness is there at 6 weeks, but they with therapy will overcome that. But I'm always a little bit nervous if I don't immobilize that long and immobilize pronosupination. If they tear because they haven't had time to heal, then refixing a TFCC that I've already fixed is going to be technically much harder. So I do err on the more conservative side of the rehab. But when they're in a cast for 6 weeks, they're working from the shoulder down. You know, therapy just looks at the wrist. But if you look at all your athletes or patients from the shoulders with ulnar wrist pain, they've all lost their periscapular muscles, their deltoid muscles, because they're not using that arm. So the therapy is working from the shoulder down.
Okay, thank you. Gustavo, you want to conclude?
Hi, my friend. No, I totally agree with what I think what Sanj said is very, very important. And I agree with Jaime that not always we need the distal radioulnar joint portals. Most of the cases, just with the 3-4 portal and the 6R portal, we are able to do a good examination of the TFCC and to check if the foveal attachment is okay or not. And as Sanj says, we do the same. We do the portal a little bit radial in these cases when we want to check in order to avoid any new injury in the foveal attachment.
Perfect. Thank you. So we continue to the next case.
It's Sergio case.
Okay.
Sergio, you're here?
Just let me
Okay.
1 minute. I'm putting the screen.
So Dr. Sergio Pombov is from the Vicente Cartala group, the fresh new INCOT, Institut Cartala de Ortopedia Traumatologia. I know that Vicente has worked really hard to create this amazing group, very professional and very productive scientifically. And they will show us a very interesting case of a Kienböck disease treated arthroscopically. Thank you, Sergio.
What a good-looking team, huh? Look at that.
Yeah,
We do our best. Thank you. Good morning. It's a great honor for me to participate in this session alongside so distinguished colleagues. Thank you very much for the invitation. As Lucian told, I work in Valencia along with Vicente Cartala. And in this webinar, we'll discuss the arthroscopic management of Kienböck disease. And the aim is to approach the topic with an analytical and critical point of view, okay? I'm also especially pleased to be here talking about this because I feel a very personal connection to this subject. Both my father and Dr. Irisarri dedicated their whole career to the study of this pathology. And for me, it's a true pleasure just to continue along with this line of work. I also recommend this monograph in which they present the long series to date of Kienböck disease, I guess. It's 100 cases. And if anyone is interested, I will be very happy to share it via email, okay? Well, this is the case. This is Juan, which is a 55-year-old male. He's a taxi driver, and he's an occasional tennis player. Not professional, but he really enjoys playing paddle. He has no other injuries or previous conditions, and he presents to my clinic with visual analogical scales of 6 out of 10, and with some limited flexor extension. This is the X-ray of the patient, and first question to my mind, just talking about obviously everybody knows that we are talking about the Kienböck disease, but the first question to my mind is what further image would I order? And in this case, I don't want to make it very, very long, okay? But what I did was asking for my best colleague. Now you can see the poll and you can make your vote. But while you are making the rotation, I just will tell you that what I did was just ask my friend, ChatGPT.
Lucian, maybe you can... Maybe, Lucian, we can get some questions from... We have Zé or Francesca, maybe they want to...
I will ask Jay what is her second level exam for these cases in which you see this kind of X-ray, because we know we are talking about Kienböck, but it's not so obvious to everybody that we are talking about Kienböck in these cases, because we see a little bit of arthrosis maybe also, so we you know, you need to be very focused on wrist surgery to think immediately about Kienböck for me.
Yes. Hi, everyone. It's good to see you guys. Can we see the X-ray again? The X-ray from the X-ray, it looks like the lunate bone is actually collapsed and it's flattened. But it'd be nice for me to see the X-ray again, if it's possible.
Can you go back, please, Sergio?
My screen is blocked. Maybe I can start again.
You can share again. Yes, if you share again, maybe it will be fine.
Yeah, so I would think about Kienböck, but it's true, you know, to the layman, it's quite difficult. You know, they may not even think about Kienböck to begin with. But in this case, it looks a little bit collapsed. There is some arthritis. I would be doing a CT scan because I want to see whether if the lunate, how fragmented this lunate is. And hopefully with the CT scan, I should be able to see the articular cartilage over the radiolunate fossa, the mid-carpal. And that would give me an idea as to, number one, how badly fragmented this lunate bone is. But to be honest with you, I might do a combination of both CT scan and MRI, because MRI can tell me as well the cartilage as well as the vascularity of the lunate bone.
Okay, perfect. And Francesca, in Europe, what we will do?
Everything. We will do CT scan and arthro. I can actually get in my hospital. I can get an arthro CT scan and an arthro MRI on the same day. I like more CT scan to check what I think there is a radiolunate arthrosis, but I prefer the MRI to check how black the lunate is.
Lucian, I
Okay.
think, thank you, Francesca. Lucian, I think the question is, because we had many times the discussion in this webinar, I think the question is, if we are lucky, we can get the MRI and the CT scan or ultra CT scan. I think the question would be, if you have one exam to choose, because not everyone is able to get both exams. The question is, if you have to choose one single exam, which one would you choose? Maybe we can have the panel discussing this. You, Lucian, what would you choose here?
You know, for me, the CT scan is very important because with the CT scan, I can really study not only the fragmentation of the lunate, but also I can study the problems of the radius and the other bones, if they are detached, if there is dissociation, because this is also very important. Not only the situation of the lunate is important for us in our management, but also the relationship between the lunate and the other bones is very important. Okay, so for me, the most important exam is the CT scan. Okay, but it's difficult not to ask an MRI also, because you can see also a bone hole in the under the lunate fossa of the radius, and I would like to see how important it is. You can see that the scaphoid maybe has some reabsorption. So I would like to see a CT scan. But how about bone scans like scintigraphy or something like this? Somebody uses it in these cases to see the uptakes in the bone?
No.
No, perfect. Only okay. So, but I would like to ask, like the panel, what is the most important thing you are seeking in a CT scan, and what is the most important thing you are seeking in an MRI? Jaime, can you tell us what are you seeking in a CT scan in a Kienböck disease? What is the most important thing you are seeking?
So CTs for, in my head, for fragmentation, and MRIs for, I would say, biological situation of the lunate, edema and so forth. Also, the CT gives you an idea of or a better idea of the collapse and what is going on with the scaphoid and this and that.
Okay, perfect. Carlos, you have something to add? I see Carlos Morales that is with us always. No?
I think
Hi, Carlos.
I think there is Gustavo wants to ask a
Gustavo
question.
wants to share
Maybe
something.
Carlos
Yes.
is running the marathon, while looking at this. I was right.
Yeah. Gustavo, you want to ask a question?
Yes. Yes.
No, it a little bit regards what Jaime said, because I don't think I really think that the CT scan is very important, because it gives us many information about the architecture of the trabecular bone. If we can fix something with a screw or not, if we can see the shape of each bone and exactly the position of each bone. But the thing is that I don't think that the MRI gives us biological information that can change our treatment. And this is my opinion. So I want to ask Jaime, that said this about the biological aspect on the MRI. What is your things that you take into account when you see the MRI, and how can change your, for example, surgical strategy?
Since I don't want to do a spoiler here, because I know the case and I know that we will approach it differently. What if we talk about this later on? Okay.
Yeah,
Okay,
indeed.
so
You are spot on. You are talking about all what I was about to say.
Maybe we can go on with the case, huh?
yes.
Okay, great.
Yeah.
Okay, really, you were spot on. Okay, because when I asked just ChatGPT, as I told you, my friend, what image I would order, the answer that was thrown to me was the MRI, but I was not very confident or so comfortable with this answer, because when I see the case, as Lucian told us before, I was very concerned about the bone cyst in the radius, and I wanted to see the position of the scaphoid, and as you can see here in this CT scan slides, we had a very big lunate cyst in the lunate fossa, and the scaphoid is not centered. Okay, so we have all this information that we really wanted to know, and probably MRI is not so important in this case for me. Indeed, just with the X-ray, we could stage according to the Lichtman classification, the Kienböck disease, because if we see the scaphoid not centered in the fossa and the ringed sign, we just could think about the stage 3B, okay, and the carpal bones are collapsed. So maybe in this case, it was more about surgical planning than just completing the diagnosis. Indeed, just as a reminder, okay, a fast reminder of the Lichtman classification, we need to assess if the lunate is intact, compromised, or in the end, we have a dead bone, okay? So this is the summary of the classification. And if we go for the 3 stages, that's the main difference. Even there is a 3C stage in which the lunate is fragmented, but it doesn't make a big difference for treatment. So for example, just to be clear, in early stages as this, MRI is very useful because I can confirm that this is a Kienböck disease, the state of the lunate. But when I'm talking about advanced stages, 3A, 3B, in these cases, the MRI, for me, in my opinion, is not very useful. Indeed, I made a revision of all the Kienböck disease cases for the last year that we had in INCOT, and it was 8 cases, and we just ordered 2 MRIs. So CT scans were more useful probably because they were advanced stages and they were going to the clinic just for advice for getting treated. Okay, so coming up to the patient, to Juan, this is the summary. Okay, he got diagnosed 20 years ago of Kienböck disease, and he rejected all treatment, and he was doing his normal daily life. But now, after 25 years, he comes asking for a solution because he can't do his normal activities. And with this test, we have to decide the treatment. And maybe this is a good point to make a stop and just discuss what options could you do for this case. Even if you need any other information, I could give you, but not arthroscopic information yet. That's about to come.
The first question I would make is arthroscopy important for you to make the decision? Okay, I know that we don't have the arthroscopic information, but we need to speak about treatment. And do you think nowadays it's essential to do a scoping of the wrist in order to finally decide the treatment? Vincent, I see that you want to say something about it.
I think if we are used to do arthroscopy, I think is for me it's essential. For me, it's mandatory because you can have CT scan, you can have MRI, you can have whatever you want, but in the end, there are things that are not completely sure in the images. So the cartilage, the scaphoid fossa, the capitate. You need information about different things that probably are not clearly enough with the image test. And for me, it's mandatory to do a wrist arthroscopy and make the treatment decision after the arthroscopy. So in the same procedure, but you need that information.
Yes, I totally agree with Vicente. Very shortly, sometimes the MRI, all the exam, they underestimate the lesions, the cartilage lesions, and also the lunate fracture. Sometimes we need we have really an accurate view on the lunate and the cartilage by arthroscopy. I agree.
Yeah, and another question is, will someone of you will try to do a leveling procedure because he's quite young and active in order to save some the bones or the articulation in these cases? Will you try to do something risky like a leveling surgery in this case, or you will go to a more traditional less salvage procedure? Ezequiel, I see your faces when I speak, so I can understand it.
No. For me, no leveling procedures. First of all, an arthroscopy. My idea here is we would like to try first to take out the lunate arthroscopically, and and obviously to check the capitate, the cartilage of the capillate of the capitate head and the lunate fossa of the radius. And then
Ezequiel, we cannot hear you very well. Sorry.
Oh, I'm sorry. Are you listening now? Better?
Yeah.
Yeah, much better.
Oh, I'm so sorry. I am the lobby of a hotel. I was saying that no leveling procedure for me. I first arthroscopy just to evaluate the cartilage. As probably this is a 3D, I will go for a lunarectomy and evaluate the cartilage of the capitate head and the lunate fossa. If that's okay, that will be, that's for me my option treatment. And if not, I may go for a arthroscopic PRC, or even if there is some damage at the cartilage at the capitate, a PRC with interposition. But my option A would be just the arthroscopic lunarectomy.
Okay. Shanj, what would you do in this case?
Yeah, so a couple of things. Great discussion. So for those that are new to arthroscopy, one of the portals that we used to be taught, but I don't think we use it very often now, is the 4-5 portal. With the Kienböck disease, I would definitely not do a 4-5 portal because you can actually injure the pedicle if you're ever thinking about doing a vascularized bone graft. So always 3-4 or 6R and 6R. I've become more, just looking at this, I've become less aggressive in these type of cases. So for me, it would be an arthroscopy to assess the cartilage surfaces. He's 55, he's a manual worker, he does paddle as well. And so for me, I would then do a partial wrist denervation. I like the core decompression to get the sort of vascularized response. And then also when you looked at that lunate facet on the radius, there was that big cyst as well. So I would probably bone graft it at the same time, knowing that if that eventually failed, then I can always do something a little bit more reconstructive. But that's sort of where I would sort of lean on this.
Okay, so you would be more conservative to the bone in this case.
Yeah, I wouldn't take out the lunate straight away. I would do a partial denervation. Okay. I would do core decompression and bone grafting of that cyst in the radius.
And Sanj, do you think sorry, just Sanj, I have a question to Sanj. Do you think you will stop the evolution of the disease if you don't do a leveling procedure, shortening, or if in the shortening, it's just the core decompression and the graft or the radius cyst will be enough to stop the evolution of the disease? Are you confident in this?
No, but when you look at the natural history of Kienböck disease, right, we published a series out of here where over time they actually burn out. So radiographically, they'd actually get worse, but clinically the symptoms burn out. And so I think that's important when you're managing these patients with Kienböck disease, that even though radiographically they can get worse, and you have to tell them this, clinically their pain can get better. So to your point, I don't think you halt the natural history of what's going on.
Okay, thank you.
Okay, thank you. Francesca, you wanted to ask a question or a comment?
Yeah, just me. I remember I had a similar case. It was a younger patient. She was like 37, and it was a grade 3C or 4. And I think in these patients, it's very important to like speak with them and know what they want. You know, like some patient they don't want to go through 3, 4, 5 surgeries. Other patients they just want the hand to be strong. Other they just want the pain removed. Like I remember I had this patient. She was a 37-year-old woman, and I said I think your knee, like it was so bad that I offered like a restart of this at the beginning, but she said I really don't want that. And I say okay, then let's try lunate arthroscopic lunarectomy, Laramendi procedure. I did also the NIP denervation, but in the end we like we managed to treat her maybe like this like for a year and a half, and right now she's scheduled to do a total restart arthrodesis. But it also depends on what the patient wants with their hand, I think.
Ezequiel, you wanted to add something?
Course. I was looking to work with Dr. Laramendi, and actually, are you listening to me? No.
We are
No,
not hearing you good.
Okay,
no.
don't worry. I will write. Don't worry.
Okay, you will write the question. I would just like to make a comment, Lucien, if you can. If we
Yeah,
have the
absolutely.
choice, the choice between a conservative and a palliative procedure, I think we need to discuss. I agree with Francesca. We need to discuss here the risk of a failure of a conservative procedure. And the thing is, if we go to a conservative procedure, for example, shortening, vascularized graft, we know that the patient will lose some range of motion. And if there is a failure, we lose range of motion, the functional outcome is not so good. And after there is a failure of this procedure, and we need to go to a palliative, secondary palliative procedure, the patient has to know this risk before. So the discussion with the patient at this stage is very important. For example, me, I would tell the patient, we can try a conservative procedure, but maybe it will not it will not work, and we will have to do a secondary palliative procedure. And some patients want to have one-shot surgery. And maybe in some cases, we need to go directly to a palliative procedure, such as a lunate excision with or without SCT fusion. In my case, I do only lunate, arthroscopic lunate, single lunate excision under arthroscopy.
I want
That
to
was
make a
my
comment.
comment.
Yeah, I want to make also a comment. I think that on the basis on the X-ray and the CT scan, I think that we will have a big damage of the cartilage of the radius and also of the lunate in this patient because he has a long-lasting Kienböck disease. So I think that people that are not doing arthroscopy will maybe do a fusion, a total wrist fusion in this case, or they will do the narration like Sanj mentioned. So I think that the arthroscopic treatment, lunectomy or a lunectomy and scaphocapitate fusion, is a mini-invasive way to treat these patients before they will go to total wrist fusion. And you can combine with this kind of surgery also the nervation if you need to. So I think it's the arthroscopic treatment is some way conservative treatment, even if we take the lunate off. This is my point of view. I don't know how do you see it. Okay, so we continue.
Okay. It's very interesting because I'm surprised about a lot of different ways of doing it. Very interesting, and a lot of conservative options, in my opinion. It's really interesting to make a connection between these Botelheiro in Portugal studies, who almost always performs radial shortening osteotomies for cases even in 3B or 3C stages. And as you previously said, with clinical good results, but not very good results in the X-rays, okay? So this is what we did. So we performed an arthroscopy, and according to Bain classification, we decided that our plan could work. What we did was scaphocapitate fusion. And I will show you shortly why and how. Because the patient wanted a one-shot procedure after so long time. And we performed the arthroscopy by usual portals, nothing strange. Just this is the position. It's very interesting to have the assistant in front of you, just doing some push and counterback. And it's useful to hold the bone gauge with your right hand, okay? So even the assistant could help you with the camera. This is the step-by-step technique. I won't go on that, but I would like to show you this video. We are seeing the radiocarpal surface from the 6U portal. And as you can see, I would make a stop just for a minute. You can see this lunate fossa, okay, which is very affected. And even above that, you can see the lunate, which is totally compromised. I mean, this is a risk for having loose bodies in the wrist. And now we are going to change our vision to the mid-carpal porters. Okay, it's very interesting to see the lunate like this. This is the most difficult part. The first bite of the lunate, okay, we are going to excise it. We are excising it with the scope on the MCR portal and, sorry, in the MCU portal, and we are using the bone gauge in the MCR portal. Okay, if you have some difficulties, you can use, as you are seeing now, a bone chisel. And so you can see we are very happy with our instruments. And it's easier for you to remove the bone if you fragmentate it, as you are seeing in this video. After completing the bone removal, which we are seeing now, you can see just the radiocarpal joint with the rotation from the midcarpal portal. You are going to see now the refreshing of the articular surfaces of the capitate and the distal scaphoid, which indeed I recommend you to do in a different order. It's easier for you if you are going to excise the lunate, make this step before, but in this case we didn't do that, so it was not so easy because everything is very mobile in this situation. Okay, so I mean, you could use different instruments, for example, a curettage, but in my opinion, it's much easier with the chisel, as you have seen before. Okay, so that's a technical step. And this is the final result after the excision, and you perform with the fusion. You can do it in this position, under the traction. And I didn't say it before, but it's very easy for you if you connect the 3-4 portal and the MCR portal, just as you're seeing in this way, and it's very easy to have the bone gauge. So you can fuse the bones in this position or in this position, just removing the traction. Gustavo, do you want to make a comment? Go ahead, please.
No, but it's just when you finish. Don't worry,
okay,
any discussion.
Okay, I'll take it into account. Don't worry.
Thank you.
So this is the final X-rays, and we always confirm under fluoroscopy, as you're seeing now, how the bones are moving. And even if we do a connection between this and we have what we have discussed before, I heard that a few of you perform the lunate excision, and I'm aware that this procedure could be performed without removing the lunate. Just a few comments about the isolated lunate excision, because there are some cases in which if you do a lunate isolated excision, you can have a proximal migration of the carpal. I mean, this carpal collapse could result in in pain and other results. So later I would like to really know if there is any tip or any way of avoiding it.
Can you stop, Sergio, just for a moment? Because my question is regarding about this. So I want to ask you and Vicente, if Lucian give me permission, that for the ones that we just do lunarectomy without any fusion between the scaphoid and the capitate, for us, I know Alam do the same and Lucian the same. For us, is mandatory to conserve the secondary stabilizers. It's very important to conserve the dorsal aspect of the lunate and the volar aspect of the lunate in order to maintain intact the DIC and the DRC. But in these cases that you are doing a scaphocapitate fusion, do you, Vicente, take care about these ligaments in order, for example, to avoid any ulnar translocation in the future, or you just remove everything because you're going to do the fusion?
No, we just remove the lunate and we perform the fusion. Nothing else. I think it's probably enough to stabilize in that way the wrist. We don't do anything about these stabilizers.
We are aware that in these cases we could just let the lunate in place. However, in this case, we decided to excise it because it's like a way of a risk of having loose bodies, or even if you have this bone cyst in the lunate fossa, as I showed before, I was concerned about having some extra pressure in the lunate bone. So I just felt that it was more to be on the safe side.
I think you can go on.
Because Gustavo, what do you do with that? So you perform the lunarectomy, and then after that you do something in the secondary stabilizers.
Well, I have done both things. I have done the scaphocapitate fusion as you show in this case. Yeah. And I have done just lunarectomy without a fusion with very nice and good results. But I think it's very important the surgery is a little bit different because it's very important to keep the DIC and the DRC when we are removing the lunate. So we have to take care about this if we are not going to do a fusion. If sometimes it's very difficult to maintain this ligament intact, so in these cases, I do recommend the scaphocapitate fusion as you show in this case. But I wanted to discuss a little bit because it's very important to see.
So maybe we can continue. Maybe we continue the discussion because I think we'll continue it after you finish because it's a very crucial point, I think.
Okay, we discuss this later.
Okay, just I will let you just an open question for you. I mean, probably there is not an only question, but I just asked to myself, what is the real cause of the pain? Because I think that maybe in early stages, synovitis is the real cause, but indeed, I don't think that the lunate vascular necrosis is the cause of pain. Maybe in advanced stages, as what I have shown is more about arthritis and carpal collapse, but I don't know, maybe all of them make a mix and they are different causes of pain. And I have to be honest, I do it, but I don't really understand why this biological storm in Aiaramendi procedures really works. So it's interesting because everybody does it, but I don't really understand it. I guess that nobody does it, but as long as it's good, it's fine. So as you said before, just a few reminders of key articles. Arthroscopic usually can change our mind during the surgery, and it's very important to talk to the patient and propose a surgery, but you have to have a plan B, because, for example, this is the Leachman and Bain classification that they gave us a few years before, and this algorithm is very useful. If you are going, for example, to perform in a stage 1 or 2B on the Bain classification, a PRC, a proximal row carpectomy because you could have some talk with the patient before. You have to be sure that this is a 2B stage, because if you have a lunate affected fossa, you have to change your plan. And we already know that 30% of the cases in arthroscopy, you have to have the plan B just to maybe change to another option. And it is important to tell to the patient that fact, because if you shouldn't do that surgery, maybe you have to change to another option. So I think maybe we could avoid this discussion, okay? Because there is no much time, but we perform the full arthroscopic PRC fusion, okay? It's not nothing that probably you haven't seen. And this is the key article, I mean, from which we extract the technique, the René Jorquera, which is a very interesting article describing the full technique of the scaphocapitate fusion. Just slight difference. We don't usually perform Ayarramendi by routine in these cases, and we don't use bone graft. And we have reached good consolidations without any problem. So just to finish, sorry about the time. I don't have conclusions, because there are not conclusions in Kienböck disease, but I just give you some points to discuss, which I'm really interested in knowing your results. For example, with lunate resuscitations, I mean, vascularized solution. I have never seen full results with this. And even, for example, I asked the question for you about what you can do if you have failure. You could do arthroscopy again, because I have a case here from Vicente in which this is a second look of Kienböck disease treated in another center with an isolated lunate excision. And just a few seconds, it's very interesting to show you how is the space between the scaphoid and the fricatum. This is the soft tissue coverage, okay, around the bones, and it's like something is maintaining in its place. In this case, we performed after that the scaphocapitate fusion, but it was very interesting to see a second look of a lunate excision. I've never seen it before. Nothing else. I just want to invite you to come to Valencia next month, and we will be really pleased to have you in the SECMA Congress organized by Vicente, and I know that many of you will be there, so we'll see your faces in person. Thank you very much.
Thank you.
Thank you, Sergio. Really nice case, very interesting. So let's continue from the last point, last discussion. You can continue, Gustavo, to say to finish your point of view. Gustavo?
I would like just to have a... Sorry.
Go ahead, Adam. Please.
No, I just wanted to make a comment, if you, Lucien, please. Just for what Gustavo was telling about the single lunate excision. When we don't perform the fusion, just the single lunate excision, it is not a complete lunate excision. It is a subtotal lunate excision, because we maintain the dorsal part of the lunate to be able to spare the dorsal intercarpal ligaments. And that is very important. And we can add dorsal reinforcement technique to try to avoid what Sergio showed us, the proximal capitate migration, the scaphoid rotation, and the ulnar translocation. So single lunate excision under arthroscopy associated with dorsal reinforcement. That's what we do if we don't plan to do to add scaphocapitate fusion, as you showed. Because Sergio, what the X-ray you showed after single lunate excision, I think it was an open lunate excision. No,
that's true. That's totally true. Yeah, that's all the cases.
Yes, so the main advantage of the arthroscopic lunate excision is sparing the dorsal intercarpal ligament to be able to do the reinforcement. So that's the only thing. The second comment or a question to Sergio is, why do we add a Liaramendi procedure? What would we add a Liaramendi procedure here?
No, I told that because in the technique described by René Jorquera,
Yeah.
he does it always. In our
Yes,
case, we don't do it.
He do it, but not for the lunate, because you are
For the
already
fusion.
with
No,
the
no,
lunate.
not for the lunate, for the
Exactly.
fusion.
For the
Exactly.
fusion.
Exactly.
Yeah.
He do it to increase the
The
healing for the
vascularization,
fusion.
the healing of exactly.
Exactly.
Okay.
Exactly.
I
It's just for
understand.
that.
Thank you.
Yeah, and I want to add to Alam's point. Actually, our X-rays are not so nice because we see bone fragments in the center where was the lunate. But I did also some dynamic X-rays and some dynamic ultrasounds, and it's amazing that the capitate doesn't go down to the radius because it has all the extrinsic ligaments that occupy the space and take all in place. So I think the lunectomy is very good. I did also fusions like Vincente showed, and I think it's also a way that if you have a failure with the lunectomy, you can add a fusion if you want to. But I think a very important key to the fusion is that you don't have to have any arthritis to the scaphoid fossa of the radius, because and it's an important thing to underline, because in this case you will have more pain because the scaphoid will be fixed in its position. Vicente, you want to comment on that?
Yeah, that's true. That's the reason I was telling you that it's mandatory to use the arthroscopy before to make the treatment decision if in each case. So you need the scaphoid fossa to be in good condition to perform this arthrodesis. If not, you're going to overload this part of the wrist, and it's going to be worse for the patient. Yeah, completely agree.
Okay. Other comments?
Just two fast things.
Jaime?
May I ask?
Yes.
Answering Sergio about the vascular grafts, we did some cases, not in a case like this. There is maybe a little past that point, but yeah. But although the wrist was doing well, we had some issues with the knee, with some cases. So we are more reluctant to happily jump to those, to those osteochondral vascularized grafts like Berger and Higginson. We have some doubts about that. And talking about other things that was just mentioned, Alam and I, we were, and you also, Lucian, online, we were in the pain meeting yesterday, so it was Delon around. It was a privilege. So I would like to ask you, Dr. Kekar, what about the denervation? Exactly, how do you do this? And what happens if, I don't know, like 2 years after all this conservative treatment is still with pain, then you will jump to these options. But by the way, the spoiler, I was going to tell you first, we, like Gustavo, Lucian, and Alam, we do arthroscopic lunatectomy. And our idea is, as much you respect the soft tissues around the lunate, lesser the risk is to have a collapse on the capitate. There are some papers, very old papers that they did open, and so far we are in the safe zone, but we'll see about that in 20 years' time.
Okay. So
Sanj. It's for Sanj, the question.
Sanj?
Yes. So just a couple of things. So I think the comment that you all made about the arthroscopic lunatectomy and the surgical technique of leaving the dorsal and volar rims of the lunate is super important. And I think you need to get that message out to many people, because most people will do it arthroscopically and take the whole thing out, because Lucian, as you said, we want nice looking x-rays. And when you leave bone behind, it doesn't look so good, and it looks like you've done a suboptimal job. So I think getting that message out is super important. And Jaime, I think your question was about the partial denervation. So I mean, typically we do it the way that Dick Berger described, just with a mini incision, just proximal to the DIUJ. What I would say though is with that paper, he discusses making the incision just proximal to the DIUJ, one finger breadth proximal to that. If you actually do it there, by that time the AIN is actually arborized, and it's very hard to find the AIN. So I actually make it a little bit more proximal, maybe an inch proximal to the sigmoid notch. And you actually see a pretty good branch of the AIN and PIN. And we found in our series, in general, of partial denivations, 2/3 of patients in manual workers do fine. They haven't needed secondary surgery. Now, but that's for all comers. That's just not Kienböck disease. That's slack wrist arthritis and everything. 1/3 of patients bought them an average of 2 years of pain relief. But I find, especially the younger patient, right? So anybody on this panel, if they present with this type of X-ray, I do worry about doing a salvage procedure in a younger patient. I think because, as you said, and as Lucian said, sometimes you put the camera in and you will see some early degenerative changes of the cartilage and the scaphoid fossa. It's not full thickness, but there's maybe some early fibrillation. So how is that going to withstand the test of time over 20, 30 years of doing, for example, a limited carpal wrist fusion? So I must admit, in the younger patient, I am a little bit more conservative in my operative algorithm because it doesn't burn any bridges down the road.
Okay, thank you very much. Gustavo, would you like to conclude this case, please?
Yeah, thank you, Lucian. So first of all, I want to congratulate both of you, to Sergio and Jaime, for your nice presentation. Also, Vicente, for your very interesting case. So I think the MRI helps guide the diagnosis, but CT scan is mandatory for treatment planning, as we said before. Arthroscopy provides the final diagnosis because we can touch, we can see the surface of the cartilage. The careful portal placement is essential to avoid damaging the lunate, as Sanj said, and treatment should be clearly discussed with the patient. As Alam said, with a more conservative approach, a second surgery may still be required. If fusion is not performed, conserve the secondary stabilizers and maintain the dorsal and the volar shell, as Alam said. As scaphocapitate fusion can be still successful, as Sergio and Vicente showed it to us.
Okay, so we are going to our last case, and we're going back to Madrid, from Madrid to Valencia, and then from Valencia back to Madrid with Jaime Ruas.
So, are you still awake for this last case? Okay. I promise I will be fast because I'm gonna.
Thank you.
I like to throw you a softball, but with a little hidden habit. Well, not hidden, but just to talk about something. So, let's go fast with this. You see me well? Yes, right? Okay. So, you are mid-office and you get a 15 years old teenager that he's super active, especially in the skiing and motorbike. That, well, people has to have their own hobbies. And for the last 6 months, he has been, complaining about pain, not much. At some point, he had a spleen for a week or so. Then he removed it. He's in that age. You know what I mean? So, well, she shows up with some pain, maybe in the snack box, but he's not the most talkative patient ever. But if you look at his wrist, he's like nothing happens. Then you get these X-rays, and you can see this funny scaphoid, and let's move on. And then we got this, and this is not healed. And I'm bringing this case apart from this edema and so on because I want to discuss with you this. So in the report said, apart from the obvious, there is no consolation of the fracture, that there are some inflammatory changes with thickening and increased intensity of the three components of the scapholunate ligament, this and that, to correlate clinically. So now you have something that is more or less clear, that you have a bony problem, but what about the ligaments? And I don't want to ruin the poll, So I'm gonna shut again, but that's the poll. Should I stop for the poll? No. Can I continue? Yes, right? I cannot hear you.
Yes, continue.
Yeah, okay, I will continue because, well.
You can, so I need to stop to share the polls if you want to continue it now.
All right, so I
because
have to stop.
It's in front of your screen, so I will stop to, I'll be stop to share.
All right.
Okay, you can go on.
All right, so let's keep going. Then, so why arthroscopy it's useful in this scenario? First, because we can see the fracture that it seems to be non-displaced. You can see how it is there, but mostly what we want to see is this, the ligaments, and how do we check those? So again, if we go back to the books and get the classification, Geisler and this and that, they are very picky on this. But we are more like before with the TFCC, more simple way of thinking. So we're gonna check. I'm gonna replay this again. If in the dorsal side there is something that will hold our probe when we try, and that the bones are gonna follow, and in the volar side too. So for us, if we can find this, we don't need to worry much about the ligament having a partial or not here. For us, this is okay. What else? The arthroscopy let us clean up a little bit that cartilage that is around. So then we do our work outside, put the screw the best we can, and then with less traction, we can check on the reduction. And also, we can go downstairs and see that we cannot see the screw going out in the corner. All right. So these are some funny pictures the mother sent me. It was summertime. This is 2 weeks. So I kept him with a removable splint, and I allowed him to go to the swimming pool and this and that because I knew he was going to do it anyway. So why I'm going to go crazy on this? This is 4 weeks. And since we were coming from a non-union, I prefer to be sure that this is healed. So this is 8 weeks. So you can see all these cuts with the screw. Where's the fracture? Well, it's healed. And also, we can be certain that there were no scapholunate ligament injury at all. And this is 12 weeks. Again, some pictures from the mom. They are not the best ones, but you can do your work with some fancy program. And he's like 3 months, I guess, after, and going back to the renal problem that is this one. I don't know if you're allowed to do this in the parking, but they were nice to send me the video, so I cannot complain about that. So thank you very much.
Thank you.
So the main conclusion is you can fix their scaphoid, but not their head, you know?
Yes, absolutely.
Okay, so some comments about this, because I think that in all courses of arthroscopy nowadays, we stress about the arthroscopic treatment of scaphoid fractures. And people that are doing open surgery and not arthroscopic tells us that we are actually exaggerating with treating by arthroscopy even such cases of scaphoid. And the main thing that we stress all the time is that a bone lesion is not only a bone lesion, but it can be bone and soft tissue lesions, like in all districts. So what do you think about it, Vicente? Tell me, how do you see it? Is it for you mandatory to do
it's true
arthroscopy?
that we always do arthroscopy for scaphoid fractures because it's true that you can find associated injuries, ligament injuries, not only it's a brace in the trauma. It's a trauma in the wrist, so you have the bone injury, but you can have a soft tissue injury, and you must know it. You must have information not only to treat that ligament, maybe you can use a cast after using the screw to fix the fracture, but you have that information to treat the patient after the surgery. And I think it's important to do the arthroscopy to reduce I think it's better to reduce the fracture, the rotation of the fracture. Sometimes it's not easy to see that rotation of the fracture in the X-ray. So to improve the reduction, to check that the screw is not inside the joint also is important, and to check the ligaments, to check the TFCC, the lunotriquetral ligament, the scapholunate ligament, and yeah, I think it's important to do the arthroscopy always.
Okay, thank you. Zareen, we
Yes, I
missed your
do.
voice this
Yeah.
webinar. We heard you too
Yes,
little,
no,
okay?
I totally agree with putting the wrist scope. I would totally put the wrist scope as well, because like there was a worry about scapholunate ligament that was torn, and also with the scaphoid fracture. I read somewhere in the literature is that if the cartilage cap is quite good, meaning that when you put in the scope, you try to put in a probe in between the scaphoid fracture site, and if it's not mobile, meaning that you will heal quite well without bone grafting. So sometimes if there's scaphoid non-union, you're thinking, okay, should I bone graft? Should I do something about it? In this kind of cases, it's really not necessary. So putting just one screw is exactly what I would do anyway for Jaime's case. So really, really good case.
Thank you for the comment, because that was my secondary reason why I bring up this case, is that there is still some room to put a screw without a graft, even though it's very fun to graft by arthroscopy. And sometimes what you just need is some compression. So to take that in mind.
Yeah.
But another thing also that is there a role in just pure core decompression without any fixation? So this is also another thing to even discuss about. Yes.
We're missing Martin here today for that discussion.
So someone would do something for the instability here?
Sanj, I see you.
Yeah, I mean, that was a great, for fracture healing, you need biology and you need stability, right? And obviously, Jaime is a great case and you've added the stability. But I must admit, I would have fixed the SL as well. I would have done a capsulodesis. I know we debate volar and dorsal or both, but looking at that arthroscopy, I definitely would have at least fixed volar, and if it tightened up dorsally, then not, and stop, or done both. So big credit to your intestinal fortitude, that you were able to do that. But I would have fixed those ligaments, and I would have casted him until So impressive results.
And in all the grades of instability, you treat the scapholunate instability. We know, for example, for the serratus fracture, there is no consensus. We treat only the high-grade instability, maybe EWAS 3C. In the cases of associated scapholunate instability to scaphoid fracture, what is your treatment? You fix everything.
It's a good question, right? So you can have acute, and it could be like a perilunate variant. You don't know. This is a chronic patient. You've seen on the MRI, it was a through and through injury. So what's the cause of the pain? Is it the scaphoid? Is it the scapholunate? Yes. It's difficult to know. So I must admit, given how good our techniques are now, I would fix both.
Yes, because thank you. I agree with Sanj, because I'm sorry, Jaime, in this case, the outcome is very good. But the thing is, we are in a chronic case. We had several traumas before. So we need to correlate. It's very difficult to correlate the pain to what we see in the arthroscopy. It's like when you have the ulnar-sided pain and you find many things on the ulnar side. So I would, in this specific case, treat the scapholunate as well in case of. But in your case, the choice was the good choice. Jaime, congratulations. Thank you.
Thank you. So as you know, we tend to be controversial in many ways. So I would say it's tempting to do things that you find, but what I was taught was to not overdo, because it's so, the damage you do overdoing sometimes surpass the benefit you get doing. So in this case, if we found like a for us a great ligament injury. We'll put the key wires, shooters, stay immobilized for 2 months. It will take a long time to recover. We did that in very high-profile athletes, but if the findings, like in the TFCC, are not like so dramatic, we will try to stay cool and not overdo, from our point of view, of course.
Yes.
Yes,
The only thing
but
with the scapholunate that we know, I agree with you, Jaime, the decision is very difficult, but because we know that if we over indicate the reinforcement, volar or dorsal, we can add some stiffness in the mid-term or the long-term outcome. So it is a difficult decision. I agree with you as well.
So it was not as easy softball after all.
But with his performance on the motorbike, I think you will have in the future possibility to treat him also for scapholunate injuries.
And maybe the neurosurgeon has a role here.
For sure. So I think that it was a great short case, and Gustavo, maybe you can conclude this case also.
Yeah, thank you, Lucian. Well, congratulations to Jaime again. So as we all think, arthroscopy is essential to confirm the reduction, especially in small residual displacement that may be missed on radiographs or even in the CT scan. And it also very important for identifying and treating associated lesions, as you can see in these cases. So it helps achieve a more accurate diagnosis and a more complete treatment. Thank you, Lucian, and thank you, Alam and Jaime and Sergio and Vicente for your presentations.
Thank you, Gustavo.
Thank you, Gustavo.
Thank you
I hope that we can all drink together beer in Valencia for the Congress. We are all very, very anxious to see the great Congress of SECMA, because our great friend Vincent is organizing it. So it will be for sure a big, big success. And then we will meet at the Mayo with Kaká. So we have a lot of meetings with very big friends in the close future. So thank you. And Alam, would you want to conclude this great afternoon?
Just, I would like to thank Jaime, Sergio, Vicente, Sergio, Gustavo, everyone, Francesca and Ezequiel, and you, Lucian. Thank you, everyone. Of course, we will have the next meeting, but don't forget the next IWC webinars. We will have one in 1 month. And I wish you all a great weekend and a great Saturday. Thank you. Bye-bye.
Thank you. Bye.
Bye, everybody.
Ciao.
Thank you.
Thank you.
Bye, guys.
Bye.
Bye.
Bye-bye.